Hey friend, welcome to Grounded, the vestibular podcast. I'm Dr. Madison Oak, aka the Vertigo Doctor. I am the vestibular physical therapist who is here to help you with all things dizziness, imbalance, and vertigo. In this podcast, we explore the fascinating world of vestibular disorders. Come with me as we dive headfirst into a journey to discover the mysteries of the brain, the inner ear, and the balance mechanisms that keep us grounded. Whether you've been managing dizziness for one day or 25 years, we're going to get real about what it takes to manage dizziness, handle the anxiety cycle, and thrive, not just survive, with your vestibular disorder. First, I want to remind you that this is never medical advice. Remember, this podcast is for informational purposes only and may not be the best fit for you and your personal situation. It shall not be construed as medical advice. The information and education provided here is not intended or implied to supplement or replace professional medical treatment, advice, and/or diagnosis. Always check with your own physician, medical professionals, and healthcare team before trying or implementing any information found here. Hello and welcome back to Grounded. Thanks so much, everyone, for being here. And thank you so much to Michelle and Eric, who are both audiologists from Hear Us Out, another excellent podcast, who are here to talk about dizziness disorders, vestibular disorders, and how they relate to hearing. So thank you so much for being here. I would love if you guys went ahead and introduced yourself. Whoever wants to go first, it's fine.
How about it?
Oh, me. All right. I am Michelle Schechter. I am an audiologist. I work with Eric at the Hearing Center. I mainly focus on hearing tests, hearing aids, and auditory processing, but have a fair share of dizziness patients come in too.
And I'm Eric Sandler. I am the director of our private practice, and I enjoy working with musicians related to audiology. I enjoy the kind of understanding of dizzy cases and really trying to unpack them and spend the time with those patients who have balance disorders. And cochlear implants also interest me. And
Awesome.
I teach. Those are kind of my areas that I like to focus on.
Awesome. Thank you so much for that. And I would love if you told everyone where your clinic is.
So we are in New Jersey. We have 4 locations kind of spread out through central New Jersey. So that's where you can find us. And then the podcast is really anywhere you stream from.
Perfect. And I will be sure to link all those things in the show notes.
Awesome.
Okay, so my first question for you guys is we can just kind of bring it back to the basics, which is, can you explain the auditory system and its kind of function, anatomy, physiology, and how it relates to the vestibular system?
Do you want me to take that or do you want to take that?
You take it. That's
right.
we're gonna have to learn how to bounce back and forth.
So the balance organs are contained within the inner ear. So as far as the anatomy goes, there's the outer ear, which you see, and then there's the middle ear, which when you hear about kids and ear infections, or when you go on a plane and you feel pressure in your ear, that's the middle ear space. And then the inner ear, which is the organ for hearing and the balance organs. That's why balance disorders also kind of fall under the audiologist purview, because the balance organs are located within the inner ear.
Awesome. So we have, if you guys are maybe new around here or new to vestibular disorders, the very first episode of this podcast ever. If you scroll, if you're listening, you're like, I need to learn about that. If you scroll all the way back, the very first episode is about the anatomy and physiology of dizziness. Sorry if you can hear my dog in the background. He's having a full mental breakdown today. If you know me on Instagram, you know Tugboat, and he is having a day. Anyway, so if you have more questions about that, definitely go listen to that. But I appreciate it because the auditory system and the vestibular system are literally the same organ. Not
And
the
the
same,
nerve
like
is
not
the same.
the nerve is the same. All of it is the same. So it's important to understand that when you have a balance disorder, oftentimes people have also hearing disorders. So my next question for you guys is if you could kind of explain why vestibular diagnoses impact your hearing system.
So that's a trickier question. And that's an answer where I would say in a lot of cases, it depends, that things will present together. There are certain hearing loss etiology, which is where does it come from, that are related to balance because It could have to do with compression on the nerve. It could have to do with um, how the chemistry of the fluid within those organs of the inner ear, how that chemistry may be working as it should or maybe not working as it should, that can be problematic. Um, there are certain things like, for example, there's something called a sudden hearing loss, which in the audiology world is like the one real emergency that we deal with. That's you wake up one day, you can't hear. You don't know why it happened, you don't know what happened, but your ear is not working. A lot of times that will present with dizziness, with vertigo, with sensation of spinning, nausea, sometimes vomiting. And our hypothesis for that is typically that it can be related to either a virus in the inner ear. On a smaller number of cases, and not to scare people, there are benign growths that can occur on the eighth nerve. There are 12 cranial nerves. The eighth one deals with hearing and vestibular organs. Um, there can be a benign growth that's compressing that can cause both hearing loss and dizziness. And then there's clue
Okay.
as to what the dizziness is originating from, and the dizziness can be a clue as to what the hearing loss may be originating from. So there are times that they both can play a role in helping us as the clinicians understand what is going on with this patient and what is the best next step to manage their case.
So sometimes we have patients that are coming in presenting with issues both in terms of hearing or vestibular. Sometimes they come in exclusively for one or the other. So sometimes they'll come in specifically complaining of hearing issues. Other times they're coming in complaining of balance, dizziness issues, not knowing that they are more intertwined than they might realize. And it can be very difficult for us to isolate, is it one or the other? Are they overlapping? It's hard for the audiologist to distinguish it. So a lot of times there could be a lot of tests involved to see what's going on.
Totally. I appreciate that too a lot because I think a lot of times people have these two things separated and they really are so intertwined. And with your interest in hearing tests, I'm curious if you could explain kind of what people should expect or can expect if they're going in to get a hearing test.
So when people are going in, when people are going in to get a hearing test, sometimes they're looking just to see where they're at. Other times they're complaining of they can hear but they can't understand. They have trouble understanding in background noise. They feel like people are mumbling. They sometimes they say they can hear everything except really soft sounds. So there's they come in with a lot of different reasonings for why they're for what brings them in the office. Sometimes they come in feeling like there's ringing in the ears. Other times they have a doctor referring them because of either ringing or dizziness presentation. So when they come in for the hearing test, we take a pretty detailed case history for the reasons of why they're coming in, and then we do some measurements of the ears to see how their eardrums are moving, how the little cells inside the organ for hearing are functioning. And then we do what are called the behavioral tests, where they're going to be hearing a series of beeps, hearing some words, where they'll have to actually respond so that we can tell the absolute softest sounds they can hear, then what's comfortable for them to hear. And then when it comes to word understanding, how good is their word understanding when we make the sound at an elevated level?
Okay. And do you guys do VNGs in your office?
We do.
Okay.
Yeah, we do.
So, what is the difference between a hearing test and a VNG or Videonystagmography exam if you're not sure what the VNG is?
Good question. So a hearing test is actually, when it comes to what we do as a hearing test, there are multiple parts that I try and explain it to patients that they're parts of a puzzle. So one test on its own might not give us a whole lot of information, but as we put it all together, we're getting a very complete picture of how the ears and the auditory system are functioning. So we have the behavioral test that we were just talking about. We do tests where we're checking the middle ear function. There are tests to check there's a reflex in the ear where the muscles of the ear actually tighten up to protect itself when there's loud sound around. We actually think from an evolutionary perspective that's rooted in protecting yourself from your own voice, because jaw movement can activate that reflex. And if you think about your own voice inside your head, it's actually a fairly loud sound. So that's something we'll also look at. We might be looking at the hair cells that are the receptor cells. They receive sound within the inner ear. The behavioral testing, then we'll do word understanding testing. We might do also testing, understanding words and background noise to get a sense of how somebody processes these complex signals that they're hearing. Now, the VNG, the balance testing that we do, that is taking a look at how is the brain handling information from the eyes and the ears, and also your body in space to keep your balance and keep everything kind of functioning properly. So that complicated name, VNG, Videonystagmography, what we're actually looking at is how are your eyes moving in response to different stimuli? So when things are going wrong or when people are feeling a spinning sensation, what's actually happening is your eyes are fluttering because your brain is getting some sort of incorrect signal that's telling you maybe you're in motion when you're not. Like if you sit up too quickly and you feel a sense of spinning, or you bend over and you feel a sense of spinning, that's your ear telling your body you're moving. So then your brain tells your eyes to move in a certain way to compensate for that. As an example, to try and understand this, if you're looking at this video on YouTube and you're looking straight ahead at us, if you turn your head, but you want to still focus on the screen, your eyes need to move at the exact speed your head is moving in the opposite direction to maintain focus. So if that reflex breaks down, you can experience dizziness, and we can measure that abnormal movement. That's what the video in that test is doing. So we're looking at how do you respond to different stimuli with lights moving, tracking across a screen. How do you respond in certain positions? If you're laying back, if your head is turned, if your body is turned, what happens with your eyes in those cases? And then there's a part of the test where we intentionally make you dizzy to measure those eye movements and make sure that they're occurring the way that they should.
I would say the trickiest part of the VNG test is that it requires for the patient to be very alert and paying attention. It is behavioral in a sense, even though we're taking some measurements, it's very behavioral. A lot of times, this test is long, it's very dark. The patients blink a lot and they get very tired. And sometimes, if they have any issues with their eyes, these are all variables that can affect the results of the test. So even if it would not be abnormal because of something dizziness related, the eye movements have to be accurate in order to assess it.
That makes a lot of sense. I feel like there is a sense of fear in the community about getting a VNG because of the part where you are intentionally making them dizzy. And I've never had a VNG. I would love to get one, just to have one.
No, you don't.
I do want to get one though, because
few.
I'm one of the probably only people on this planet who wants one. But I want to know what my patients are. I don't have a vestibular disorder, so I've had BBBV before, but I don't have vestibular migraine. I think a lot of people think that I do, but I don't. But I want to know what a VNG feels like. And where I learned to do vestibular rehab, they had a VNG, and it just never happened when I worked there. So anyway, but I think a lot of people are afraid of the VNG, and I think I'd like to clear some things up about that because it is an important test. Not everyone needs one. Some people do, some people don't. Um, as far as physical therapy goes, it doesn't necessarily always change my plan of care, but it might change your plan of care with your audiologist. It might change your plan of care with your MD. It might change your diagnosis if you thought you had one thing, but actually have another thing. And I think that's interesting. Maybe we should clear the air on the VNG. Yes, it is going to make you dizzy, but
Yeah, one thing I think is really important, and this is something that we try and make clinicians we're training aware of, and I think it does carry over to any aspect of healthcare. I think it's incredibly important to narrate to your patients. Don't ever surprise your patient. Let them know what you're doing, and to the extent that you can, let them know what to expect. So with the VNG, with the calorics are the part of the test that people don't like. And caloric, it's rooted in the idea of heat, temperature. So what's happening is either air or water is being introduced into the ear, warm air or cool air, or warm water or cool water. And what the expectation is that change in temperature going into the inner ear changes the way the fluid of the inner ear moves. And that simulates motion for the brain. And as we were talking about before, that simulated motion, then the brain sends a message to the eyes that the eyes need to move in a certain way. When we're doing the test, we can see on a screen what's happening with the eyes. So we can have a good idea when that patient is starting to feel whatever it is they're feeling from that test. And if, as that's occurring, you can say to your patient, hey, are you starting to notice a little bit of motion? Are you starting to feel that you're moving? And yes, yes. How can you tell? We can see it on the screen. I've got you. You might start to feel that a little bit more as we see those eye movements build up a little bit more. You might say, okay, this air is going to be in your ear for another 10 seconds. So we're trying to keep people um, aware of what's happening, and that so much, and we'll probably get into this more, of what's happening when people are experiencing dizziness or a vestibular disorder, it triggers anxiety for them. And if we don't narrate to our patients, that's exactly what we see. And if we can narrate, it can help to calm the anxieties that occur within that test and make it a much more manageable experience for the patient. So when a patient knows, you can tell what's happening with them to a degree, and you can walk them through that process as they're experiencing it and let them know it's going to start to subside. Because one of the fears with dizziness is ever going to stop? Well, yes, as soon as I pull that air away, you're going to really feel it. Then it's going to start to go away as I have you focus on something. So it's really important to narrate, and then people look this test up online and see horror stories and they get terrified about what's going to happen. It can really be made a lot easier by ahead of time. We'll take our history and then we'll go point by point. This is what we're going to do. This is what you're likely going to experience. And when we get to those points of the test, we'll say it again.
What I like to do is I'll tell them, sometimes they're afraid that they're physically going to fall off the table. So I'll tell them, and if I have somebody with me, I'll say, we're each going to stand on one side of the table. We're not going to let you fall. Even if you feel like you're moving, you're not moving, and you won't move off the table. And knowing that sometimes can help. And at least for some equipment, what we have is, as the dizziness starts to subside, and as Eric said, when they can start focusing on something, there can be a red dot that they can see on the goggles that they're wearing. And when you say, okay, the red dot is going to appear very soon, and you'll start focusing on that, that's going to help the dizziness subside a bit. And then when they see it, it almost puts this sense of trust of, okay, it's going exactly as they said it was going to go. It's going to start to get better.
Totally. That makes a lot of sense. And I think for a lot of people, some of the fear will come from, is this going to trigger an attack?
Yes.
And for people with chronic dizziness, let's say vestibular migraine or Meniere's disease or something like that, having kind of being prepared for the rest of the day to say, hey, the rest of my day might not be my favorite. It might not be the best day ever post calorics part of the test, which is the last part of the test. You don't do it first.
Yes.
If that is the case, okay, maybe I have someone to drive me home. I know people who pack snacks and bubbly things and ginger and stuff to have on the ride home or the walk home, however that is for you. And I think just being prepared that, hey, maybe this isn't going to be my favorite thing, but I am going to get through it. I'm not going to fall off the table. Someone's going to walk me through it. And you can even ask, like, hey, can I have extra things that you tell me? And kind of advocating for yourself if you are going to get a VNG in that way can be really helpful, and asking kind of exactly for what you guys said. But in case you find your audiologist on their off day or something like that, where you're like, hey, like maybe the audiologist isn't having the best like memory day, right? Sometimes we forget to do things at work and it's okay. But maybe reminding them, hey, can you really walk me through what you're doing? Can be really helpful, because it can be an important test. It can be really helpful. And if you do need one, knowing what you're in for is important.
Some patients want more narration than
Mm-hmm.
others. So if you are somebody who is comforted by knowing each step of the process, ask. I'm sure your
Mm-hmm.
clinician will be happy to do that for you, but just ask.
Totally.
If something's occurring in your appointment that you're not feeling good about, ask for
Mm-hmm.
what you need. It's the most likely way to get it.
Mm-hmm.
We book a
Totally.
lot of time for these appointments because we expect a lot of questions, and we expect that people will want to take their time or take some breaks because it's a lengthy test. So we allot time for that. It actually surprises me how many people come in for VNGs and they have no idea what to expect. They kind of say, what am I doing here? What's on the agenda today? They weren't told by their referring physician what's going to happen. They just know that they need this test with an acronym.
Test with an acronym. I mean, it is such a long name, but
Yeah.
yeah, I feel like there's definitely two groups of people, the people who Google everything and feel like they know everything, but then it's maybe terrifying because you went down a rabbit hole on a bad Reddit thread or a Facebook post. And then the people who have no idea what's going on. And I don't think there's a better or worse way to be, but asking your clinicians questions, especially when you're in the audiologist office or the PT's office, where we typically tend to have a little bit more time, will be really helpful for you. Okay. My next question is, this is a question, I don't know, I'm just going to say it. Okay. So vestibular
Go
neuritis
for
and
it.
vestibular labyrinthitis, people get them very, very confused. They are not, well, they are almost the same diagnosis, but not the same. One has
Mhm.
hearing loss and one does not. When you're looking at an audiogram, so the hearing test, and you're like, oh, this person, let's say, has Meniere's disease, because there's that low frequency hearing loss that we can see, and we can talk more
Mhm.
about that in a second. What kind of hearing loss do you see on labyrinthitis? Because I see a lot of audiograms and a lot of misdiagnosed labyrinthitis that doesn't have any hearing loss and some does. And so I'd love if we could kind of clear the air on that while I have you guys here.
So the type of hearing loss that you will see will vary.
Okay.
Um, Oftentimes, and I'll use a very scientific term, it's significant loss. Uh,
Okay.
you could have an asymmetry that's moderate. You can have an
Hmm.
asymmetry that is profound because of what's going on.
Hmm.
Those losses do not always present in the same way. One of the things, though, that is very, very common is a decrease in word understanding.
Hmm.
So when we look at think of hearing as having two components. One is, can your ear detect the sound? And the other is, what does your brain do with that sound once it gets it from the ear? So when we talk about a moderate or severe or profound loss, we're talking about how loud does the sound have to be for you to detect it. But then when we talk about word understanding, that's something that is more complicated. And a lot
Hmm.
of times in these cases, we will see impaired word understanding. The best way I can describe that is, if you remember back to when people used to listen to AM radio and you would go under a tunnel or an overpass and you hear for a little bit, that's kind of what it's like to have impaired word understanding, that you hear sound, but it's not clear and you can't make it out. And
Hmm.
that's very, very common with those diagnoses, and we can't always recover that.
Okay, that makes sense. Um, this is sort of off topic, but also not. I'm curious then. So I've heard when you have reduced word understanding, a lot of people are like, well, I can hear and I don't want to get a hearing aid. Um, I'm very much in support of getting the hearing aid. Like they're so tiny now, and it's amazing the technology you guys have. It's truly unbelievable. You can't even see them most of the time, but a lot of people still are like, I don't want to get one for whatever reason.
Mhm.
I would love to talk about why it's so important to have a hearing aid if you cannot hear correctly or cannot understand words correctly, because I do believe that it can lead to other diagnoses like difficulty with memory impairment, dementia, stuff like that as well. Is that true?
Sure. So I'm going to call it there could be a correlation between hearing loss and cognitive decline. So the intertwinement with those is that if you have hearing loss, pretty significant hearing loss, and you don't do anything to manage it, it ends up leading to withdrawal in terms of social activities and stimulation that you're not participating in things. The wheels in your brain are not turning, and you're sitting at home and you're doing nothing. And when the wheels in your brain are not turning, that can lead to the cognitive decline. So is it a causation? Not necessarily. It's more that because you are not keeping your brain active, because you're not hearing, that's what can ultimately lead to that. So when it comes to us having the hearing aid or cochlear implant conversation, especially with people with impaired word understanding, our counseling really goes into effect there, because when people have very impaired word understanding, we can make the hearing aid as loud as it can go, and it's not going to be very clear for them. They'll hear something, but it's not going to be very clear. So the ceiling of how well they can do with hearing aids is definitely going to be more limited. It will help with sound awareness, and it might even be their best option, but we have to really counsel them. This will be a good option for you, or an option for you, but you will never hear great. When we reach the point that hearing aids are really providing very limited benefit, that's when the cochlear implant conversation comes into play, assuming that they are somebody who medically can be a candidate for it. Then we say that hearing aids will give you the volume, not really the clarity. Cochlear implants can have the ability to give back, or to not restore, but improve clarity. But it's a process. It is not something that happens overnight. It's a surgical procedure that then requires pretty intense follow-up and work on the patient's part, on our part. So that's a full-on conversation that requires its own evaluation in itself.
That makes a lot of sense. Thanks for explaining that. So
Eric, your mic.
Whoops. I wanted to add one thing to that's really important. In order to decide when somebody has poor word understanding, if they can benefit from a hearing aid, you cannot just rely on a test result. So years ago, if you saw somebody had, let's say, 88% word discrimination in one ear and 24% in the poor ear, you wouldn't recommend a hearing aid for that ear. What we know now is that you don't know until you try a hearing aid on that ear. So our kind of guiding principle within that is that if putting a hearing aid on the poor ear does not impair the overall hearing and the patient can tolerate it, we strongly recommend a hearing aid for both ears. So if we put a hearing aid on both ears and then we test you for word understanding with the hearing aids on, and your score with both ears is 88% or better, I'm going to recommend a hearing aid in both ears as long as you can tolerate it, because there are still benefits of having sound from both sides. You can better localize and find sound in space. Or, as Michelle was talking about cochlear implants, the longer you're keeping that nerve active, the greater likelihood for success with a CI if you eventually go that route. So our thinking in what ears can be aided has grown over the years as we've learned more. So if you're somebody with poor word understanding, certainly in one ear, maybe in both, you don't know if a hearing aid will work for you until you try it. And again, as Michelle was saying, that ceiling for how well you can do with a hearing aid is going to be lower than somebody who has good word understanding in both ears. But it doesn't mean that your best option or your best option still could be a hearing aid in both ears.
Okay. That makes a lot of sense. One thing you said that I want to go back on, because I have seen a lot of patients, especially back when I lived in New York City and saw people in person and had just like a crazy full caseload all the time. I would see a lot of patients who were hard of hearing or deaf, or and also had balance disorders or balance deficits. And I would talk to them about this concept of having an auditory bubble that they don't have, right? Because they cannot hear, therefore don't have this auditory awareness. And I heard you say that word, and I'm obviously not an audiologist, and so that's not something I can explain well, but I'm curious if you could explain kind of what you mean by this auditory awareness, because if someone's coming up behind you, you know, even if they're like walking on silent feet, if that makes sense, like you always know they're there. And that is kind of your auditory awareness. And I'm curious if you can explain how that works. Either of you.
Do you want me to take that? All right. So it's a really interesting concept, this idea of sound localization. So if you only have one hearing aid in and you have hearing loss in both ears, or even if you have normal hearing and you put an earplug in one ear, if you try and listen, finding sound in space becomes very complicated. You don't know the direction the sound is coming from. As an example of this, when you're driving, walking, whatever, and you hear a siren, when you first hear that siren, you don't know where it is. That's what it's like to listen with one ear. The reason why you can't find that siren is because the frequency of that sound occurs in a space where the brain can't localize sound. Low frequency sounds we can find because the wave is slightly different at one ear versus the other ear. High frequency sounds, the intensity of the sound is slightly different from one ear compared to the other ear. Don't know how, but the brain calculates that and finds where that sound is coming from in space. Sirens are not low frequency enough to be able to tell based on the phase of the wave. They're not high frequency enough to be able to tell by the interaural, the one ear to the other sound difference. So we can't find them until they get pretty close to us. So whoever designed sirens didn't understand the way the ear functioned.
Huh.
So
Or they
Next
did
time
and they did
you-
it on purpose.
right,
next
and they would
time,
be
next time
punking
anybody
all of us.
listening hears a siren, try and see if you could find it, because you probably can't initially.
I had noticed
Yeah.
that I have to look for the lights.
Yep. And,
Yeah.
and this is the physiological reason why. Um, so if we can preserve that localization, that's one of the greatest benefits of a hearing aid in both ears if there's aidable hearing, and keeping that nerve active and aware to sound will, if treatments ever change or if you go a different route like CI, allows for that hopefully better performance, better outcome.
Fascinating.
The longer the duration where the nerve is not getting that stimulation, the less it's going to know down the road what to do with that sound. So we've had patients that have been that have had these profound hearing losses for 30 plus years. They're going to have and have not had any sort of hearing aid or any sort of aided stimulation. And if we suddenly put a hearing aid on them, it's going to be very difficult for the brain to interpret what that is. And it's going to sound like mush, and it's going to sound pretty awful to the patient.
That makes sense. Huh. Okay. I appreciate you explaining that to me, because you can find it in research, but it's not something that's clearly explained on the internet.
Yeah.
I know it's one of those things, like, I know this is a thing, but I cannot explain it back to you.
Yes.
Perfect.
I think, as Eric was also saying, probably decades ago, if one ear was shown to have 20% word understanding, it's less likely than now that they would be aided with a hearing aid. So it's not in the older textbooks, so it might not be as searchable as it probably is now, or that it's starting to be much more recognized that even an ear that has very poor word understanding can still be aided. It doesn't have to go with nothing.
Yeah,
That's
this is
amazing.
an idea we've kicked around presenting at conferences because it really needs more awareness.
Yeah, that's a good idea. Huh. Okay. So my next question is about hearing loss in vestibular disorders. Now, I know I've asked you this like 4 times already in different ways about different diagnoses, but so labyrinthitis could have, kind of circling back, any type of hearing loss. It's not specific, but hearing loss plus vestibular loss is definitionally would be labyrinthitis, where neuritis is vestibular loss without the hearing loss, which is the differentiating factor there. Meniere's disease has a low frequency hearing loss that you will see very distinctly on usually just one side, sometimes both, but typically just one. Now vestibular migraine is one where I hear about a lot of people saying, like, I have hearing loss. Tinnitus is different. We can talk about that in a second, or tinnitus, however we want to say it. But my question is, do you guys see a lot of hearing loss that is sustained in vestibular migraine? Do you guys see a lot of vestibular migraine, or is it, I don't know if it comes to your clinic very often, but people complain of hearing loss or maybe difficulty with word discrimination. I'm not really sure. But it's not in any clinical criteria, anything like that. And so I'm curious about it.
So I'm going to go a little outside of research and speculate a little bit here that First of all, I think vestibular migraine is very underdiagnosed, that it's oftentimes
Oh
missed.
yeah.
You
We'll
know
see the
that?
patient who's seen multiple providers and it's, wait, has anybody ever spoken to you about this? No? Okay, I think this is a direction to be looking. Um, what I wonder about is if what patients are reporting would almost be like a brain fog, auditory processing
Mm-hmm.
related issue in the midst of an occurrence.
Mm-hmm.
So you're suffering from, we'll call it this attack, and you're so activated in terms of your nervous system that focusing and interpreting sound can be more complicated.
Mm-hmm.
So I'm wondering if that's an aspect of it. And
Mm-hmm.
another thing that I could potentially see occurring is that people who are suffering from vestibular migraine, at least what I've seen, they're not typically 15-year-olds. So they can be older. A lot of times hearing loss goes undiagnosed, but when you present with vestibular symptoms, it's going to be proper to recommend a hearing test. So somebody could then have a test done, hearing loss is uncovered that's not impacting their life, so it never brought them into a doctor's office, but it's
Incidental.
found
Yeah.
incidental to
Yeah.
this dizziness that's occurring or vestibular dysfunction that's occurring. So then they connect the two when they may not be related. So
That makes sense.
I don't typically expect an audiogram finding for vestibular migraine.
Or at least anything that's specific or
Yeah.
has
Okay.
a typical
Like it
pattern.
will be like every vestibular migraine patient I see will have X, Y, and Z. You will not
Yeah.
expect that. Yeah.
No, I would not expect
Okay.
that.
Me
No.
too. Okay. That makes a lot of
Which
sense though.
adds to the complication of the
Oh,
diagnosis of
totally.
things.
Super complicated. But also, I'm going to go out here on a limb and say this. I think in the next 3 to 5 years, vestibular migraine will be more commonly diagnosed than BPPV.
I
I
hope
mean,
so because there
annual
are way too
incidence.
many BPPV diagnoses.
And I am convinced that a
You
lot
know,
of it is undiagnosed vestibular migraine because it also causes positional vertigo but it doesn't go away with the Epley maneuver and it drives people crazy and they send me emails. Like I need to start like going through my email and do like a retrospective study because I get so many emails a week being like, I have this weird, I obviously cannot give medical advice, will not give medical advice to people who are not my patients, but I have this weird thing. The Epley maneuver won't work. It keeps coming back. I'm so uncomfortable. It lasts for so long. I also have light sensitivity. The whatever. They'll send me this long email, and I'm like, okay, well, I can't give you medical advice, but you should go see a headache specialist. And then I get an email back like 6 weeks later that they're, or however long it took them to get an appointment, say, oh yeah, I do have vestibular migraine, like all the time,
yeah.
and it is just
Yeah.
undiagnosed. Flipping. They say 3% of the adult population has VM. Um, and I think it's way more than that.
And one thing that's really stood out to me as we've kind of entered into this podcast world and have been talking to providers and clinicians that have been looking at all alternate delivery models for care, I think these experiences that fall under kind of a chronic disorder umbrella are going to find alternative treatment models that did not previously exist. So within audiology, we have tinnitus, we have dizziness, we have what we call oral rehab, which is helping people to better be able to understand what it is they're hearing and function better in the world, better understanding of speech in spite of their hearing
Cool.
loss. That all of these things I would put under an umbrella of a chronic condition. Those chronic conditions were oftentimes ignored. Hey, your dizziness, here's meclizine. Oh, you have tinnitus, too bad, there's nothing we could do for it. Oral rehab, yeah, your word understanding is poor, their hearing aids aren't going to fix that. But now, as providers are seeing that there's alternative routes to access these patients and alternative ways of supporting patients who are experiencing these disorders, I think that there's a lot of potential. And I think there's a lot of room for growth, and I think there's a lot of room for success for patients
Totally.
who are having all these different experiences.
Absolutely. And there's a newer book called Good Energy I feel like everyone is reading this book right now. And I started it the other day. It's, if you don't know the book, it's by Callie Means, and her brother Casey Means is like the co-author on it. And the very first 2 pages is a case, not a case study, but this doctor's recollection as an ENT, a surgical ENT of her very first patient, or not her very, a patient who changed the direction of the way she practices. And the patient has vestibular migraine. And like it is that common. It is all over the place. And it does not specifically say vestibular migraine, but it's dizziness with migraine. It's VM. Like, let's be real, people. But it's so common. And I think that there are so many alternative ways to treat people than like, here's another injection, here's another medication, here's another whatever it is. And that's really how my practice became a thing also, because there's just so many other ways besides shaking your head around to feel better with dizziness. Unless it's neuritis, then please go shake your head every which way in the world. You will feel better.
And I know that when you were on our podcast, you also talked about lifestyle incorporations
Exactly.
that I think a lot of clinicians or people working with dizziness patients take a more holistic approach than the, as Eric said, the handing them meclizine. It's more rehabilitative, it's lifestyle changes, and combining all those factors, even if it doesn't eliminate the problem, my expectation is that it significantly reduces the problem.
100%. I totally agree. And I think it's difficult to get the average American to reduce all their processed foods, including the pretzels and the crackers. It's really difficult to get people to drink more water and sleep 8 hours and do all the things that we need to do as humans, because life is stressful and things are hard, and I get it. But also at the exact same time, when you live with a chronic condition, whether it's dizziness or pain or whatever else, it is absolutely essential to do those things, because we're finding more and more the reason that we have chronic illness in the first place is because of those factors going wrong. And it's important to remember. Off topic.
Whenever we see tinnitus patients come in, almost everyone asks me, when I talked about the different management options, they'll say there's no medication that can fix this, because it's so much easier to
So much
have a
easier.
pill once a day than to manage it themselves. And it requires work, but it's a lot harder to do the work.
It totally is, but we give out more statins, right? And heart disease gets worse. We give out more SSRIs and SNRIs. Our depression rates have never been worse. And it's like, these things aren't necessarily actually fixing your problem. The rates are just as bad, if not worse, than they were 10, 20, 30 years ago. Why do we think that this is working? And clearly we need to take it back to like a root cause perspective of, okay, you do need to put in the work to fix this if you do want something done. Which is a perfect segue into tinnitus. What is it? Why does it happen? What do we do about it? I have tinnitus. I have no hearing loss. I have no vestibular disorder. I am far less stressed than I was 10 years ago. Do I what? Grind my teeth? I do grind my teeth. But
that could be
it's gotten a lot better recently about grinding my teeth. Okay, continue. Please tell me.
Have you been feeling less stressed lately?
Yes, way less stressed. But my tinnitus is still there.
Yeah, so
I don't need a lot of salt.
Tinnitus can be caused by a lot of things, and it can be caused by, most commonly, by hearing loss. That, hey, you're not hearing as well as you once were. Your brain kind of fills in that empty space where it's not getting the sound it used to with the sound it's creating. But it can also be rooted in dental issues, no pun intended. It can be rooted in jaw clenching and muscle tension. It can be rooted in your spine and cervical tension. It also can be exacerbated by stress. Like, for example, we'll see people who have had hearing loss, but now all of a sudden they have tinnitus. And they say, well, this isn't from my hearing loss because I've had hearing loss, but I haven't had tinnitus. Well, you had an activating event that, because you were predisposed to experiencing tinnitus because of your hearing loss, now you're experiencing that tinnitus. Hey, has anything happened recently? Oh, your spouse died? Okay, that makes sense. Like, these are things we encounter clinically. So we'll also hear, I can't lower my stress. Well, if you're not willing to work on tools to manage stress when we all have stressful lives, I don't know that we can get your tinnitus to be better, because it's not something that a medicine or surgery is going to fix. So let's look at those alternate routes to manage and habituate to it so that it doesn't take over
Absolutely.
your life and become something unmanageable.
Totally.
Tinnitus can also, there are temporary types where if you're exposed to very loud noise like concerts or um, gunfire, anything like that, you can have what's called temporary hearing loss and tinnitus from that loud noise exposure. But if it goes on for a long period of time, meaning if you go to a lot of concerts over many years, you can lead to permanent damage. Even if it's not fully causing hearing loss, if your brain is recognizing a change in the hearing, even if it's still normal, it can exacerbate or start, it can create the effect of tinnitus.
That makes a lot of sense.
Yeah, kind of piggybacking on
Mhm.
that, with hearing, there's a normal range. So you can shift within a normal range and still on paper technically be normal, but experience what we would call functional impairment, where it's harming you out in the real world, or you're experiencing tinnitus, even though your hearing's normal, but it's not quite as normal as it used to be.
Totally. I I would love if you guys could speak to what the things are. So there's no surgical intervention. There is no pill. I might take it at this point, honestly, if there was. It doesn't, but I'm part of the 50% of people that it doesn't drive me crazy. It's a part of my life. It doesn't drive me crazy. It's there. It's like, okay, sometimes at night it's kind of annoying if I do go to a concert or something loud, but did I have you on this podcast just so I can ask this question? The world may never know. But no, I'm
Possibly.
just kidding. But no, but what are the things the things that I know are less caffeine, sodium, stress, probably sleep well. Okay, don't grind your teeth. There's definitely a ear jaw connection. What other things or what things would you guys say you see be most helpful for tinnitus?
So for our patients that have hearing loss and tinnitus accompanies that, we recommend hearing aids because managing the hearing loss often will manage the tinnitus as well. Because when we're giving the patient the sound back that they're missing, the brain doesn't have to compensate or fill in that space because it has more sound to focus on. And then we find that the tinnitus tends to decrease, even if it's not fully, if it doesn't fully go away. For them, it often brings peace of mind that, hey, it can actually get better. It doesn't have to be this loud all the time and constant. Then what we're doing is we're breaking what we call the tinnitus loop or the tinnitus cycle, because what we find is that the patient has tinnitus, then they think about it, and then it gets louder, and then they think about it more. And if
The
we can
same as
even break that,
dizziness.
exactly.
Yeah.
And if we can break that cycle for even 5 minutes, it gives them some peace of mind. What comes with hearing aids, and this is only one source of management, but sometimes hearing aids by themselves can do the trick. Other times it can't do the trick by itself. So there's something called a tinnitus masker, which is incorporated in hearing aids, which whether they have hearing loss or not, this can be a useful tool that if the extra sound stimulation is not quite doing enough, you can add in more pleasing sounds, if you will, where it's like ocean sounds, rainforest sounds. It's still playing an actual sound, but it's way less annoying than the sound that they're actually hearing. And by giving them something that is more pleasing to the ear, it again gives the brain something else to focus on, something external that can help break that cycle. There is something also that's called tinnitus retraining therapy, where you sit with the clinician and you work strategically with the clinician on how to week by week form more cognitive strategies to help reduce the tinnitus. Again, we don't want to go with the expectation of it will be eliminated, it will be gone forever, but we're trying to reduce it to break the cycle.
Totally. I
would
had this.
also
Oh, go for it.
I'd add to that, probably the most important thing you can do on the preventative end is ear protection. So if you're doing yard work, if you're going to concerts, if you have firearms exposure, if you are a musician where you just play at home, ear protection is the best thing you can do to preserve your hearing and try and stave off tinnitus. And to piggyback on what Michelle said about hearing aids for a treatment option when it comes to tinnitus, when you have hearing loss and you are going through your daily life, you are exerting a lot of energy to listen and understand. That is putting stress on your brain. That's a means of increasing stress that you don't even actively realize is happening. So that can exacerbate your tinnitus. So getting hearing aids to take some of that load off your brain can be helpful to help reduce tinnitus in that sort of case as well.
That makes sense. I feel like there's maybe 50% of people with tinnitus who it drives them crazy and they will go to the ends of the earth to get rid of it. And then half the people who just don't care.
We
I
say that
am,
we have our
oh, no,
we
go
say
for
that
it.
we have our patients with tinnitus and our tinnitus patients.
Oh, that makes sense. That makes a lot of sense.
And
Yeah, I am
but what I
of
would
the don't care,
say,
but I have a
I,
guy. Oh, hold on. I have this guy in back to when I lived in New York who went around. He wore Bose sunglasses that had a Bluetooth attachment that played crickets in his ears all day. And he was flying to Ireland for a clinical study where they pierced his tongue with some like thing that was
Linear.
supposed to make his tinnitus go away, like ends of
Yeah,
the earth. And it's so interesting.
yeah, there's a new device, Linear, that helps, that's supposed to have kind of clinical backing that it's beneficial for tinnitus patients. Um, I would actually say it's a smaller percentage of patients where they fall into that tinnitus patient category. The majority of our patients that have tinnitus, it's an annoyance as opposed to something that is overwhelming. Uh, I can tell you a story back from, I was around 2014. I had a patient who had severe tinnitus, had very significant hearing loss, but also had severe tinnitus. And the tinnitus was what he was seeking relief from, not the hearing loss. So we recommended hearing aids, we set him up and thought he had some improvement. I set him up on a Wednesday. By Friday, I had already seen him back for follow-up. We'd had multiple phone conversations. Friday afternoon, I think I stepped out of the office for a little bit and I had like 3 or 4 phone messages from this patient. And I had never before, as a clinician, been concerned about a patient harming themselves. And this was a case where that came up. And it was one of those like, hey, it doesn't matter that it's Friday night. We need to address this. We need to get in front of whatever it is that you're experiencing because for you in this moment, it is absolutely unmanageable. And
Mm.
that's the rare end of the tinnitus patients, and it does occur, but I don't want to skew the thought that tinnitus is hopeless because a lot of people leave their doctor's office when they hear there's nothing that can be done for it. What that means is there's nothing medically or surgically that can be done.
Correct.
There is hope for you if you have tinnitus. You don't have to get to that extreme. And even if you do, there's hope. But recognize that when a clinician, most likely a physician, says to you that there's nothing they can do for your tinnitus or you just have to get used to it, doesn't mean you have to get used to it on your own. There are professionals that can help guide you to develop strategies to get used to the tinnitus. It can be done. You can habituate, you can get used to it, but take advantage of the professionals that are out there that can help you achieve that.
I appreciate that commentary because the same thing is my ENT where I live said to me, well, I don't like treating dizziness because there's nothing you can do about it. And just because meclizine usually doesn't work doesn't mean that like there's nothing you can do about it just because there's not a surgical intervention or a medication that works for everyone across the board or whatever. So I think it's so important to know just because this prescription pad can't make it better doesn't mean that things don't get better. Dizziness gets better, tinnitus gets better. Mine is getting so much better, just for the record. But it is a really curious thing, and I know a lot of people have questions about it.
And it's very disconcerting for people. Like, what is this sound I'm hearing? Why is this happening? But we
Absolutely.
can help you.
Yeah, yay. What is the difference? This is my last question, I think.
Yeah.
What is the difference between pulsatile tinnitus and ringing? Is there a difference, or it's just the sound that your brain has decided you to have?
Do you want to take that? Do you want me to take that?
Well, the pulsatile tinnitus, the way that we ask it is, does it sound more like a heartbeat? Whereas the that requires a referral to an ENT, because that could be indicative of something that's not necessarily ear related. Whereas the I'm going to call it typical tinnitus is much more likely to be related to hearing loss, or as Eric had said earlier, dental related, more likely in terms of hearing loss. But it would require a different set of referrals. Pulsatile, we always refer to an ENT.
Okay.
Yeah, the pulsatile tinnitus, and again, this can be rare. There can be other explanations. It could be related to eustachian tube dysfunction. It could be related to fluid in the ear. It can have benign underlying cause, but it can also be the first and only symptom of a carotid blockage. That's why we take it seriously. So, or restricted vascular blood flow within the neck. So what should be recommended in those cases would be an ultrasound of the carotid to view if blood flow is normal there or not. So when we hear pulsatile tinnitus, it's something we always take seriously, and it does warrant a medical referral. And if any of the listeners are experiencing, and what we mean by pulsatile is it sounds like your heartbeat. So if you're relaxed, it'll be slower. If you're active, you'll hear it more boop, 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 boop. If that is occurring, follow up with your physician and make sure you are describing it as your heartbeat, and ask them what tests need to be done because I hear my heartbeat in my ear. Even if you have hearing loss.
Okay.
Doesn't matter. If you have that symptom, it warrants follow-up.
Okay.
And
go for it.
And sometimes patients have a difficult time describing what they're hearing. And in those cases, we like to err on the safe side, that if you think it's something that's thumping or your heartbeat in your ear pulsing, but they're not quite sure, it's just better to make the referral to an ENT just so that they can look into it further. It doesn't necessarily mean that it's anything harmful, but we always like an extra medical professional to take a look.
Totally. And it should be an ultra. Oh yeah, go for it.
I was going to add in one funny story. Again, earlier on when I was a younger clinician, when you have tinnitus can be broken up into two categories. One is subjective, meaning the patient hears it, but you can't verify that they're hearing it or what they're hearing. The other is objective tinnitus, meaning you as the clinician can hear it. Once in my life, I've had that occur. And what it was in that case was a hiccuping of the eustachian tube where there's a flutter. So in very, very, very rare cases, that pulsatile or thumping tinnitus can be related, well, it can be audible for somebody outside. But when I was saying before that it could be related to the eustachian tube, the kind of top of the eustachian tube can flap, and that can sometimes be audible for the person. And that can sound like a flutter or a little thumping sound. So that's the distinction we want to make, but we want to make sure it's not vascular blood flow related.
Got it. And so they should do more than just look in your ear. They should request.
You can't see anything. Either of those, you can't see it.
Okay. Makes sense. All right.
But that's more of a zebra.
Totally. All right. Anything else, you guys? I appreciate all of your time.
Thank you for having us. The very first day that I met Eric, he had asked me, what is one of the most important things in audiology? And I didn't know the answer. And he said, keep a garbage can when you're doing a VNG, just in case. You never know. So for any clinicians out there listening, just in case your patient probably won't vomit, but you heard it from me through him, keep a garbage can handy.
And if you're narrating to your patient, the likelihood of that happening is so much lower. So
it's true.
Narrate what you're doing to your patient. And for the students, when your supervisor asks you the most important part of the VNG, it is not some complicated thing on page 267 in your textbook. It's a garbage can with a fresh bag.
Same if you're treating BPPV. If you have a trash can, they will not puke. If you don't, it will end up on you. Has that happened?
Oh, yeah.
Yes.
Residency reminders.
Exactly. Thank you so much for listening, everyone. We will see you next week.